Hi everyone, cameras on, please.
Hi.
Lovely. How's everyone's Wednesday going? Middle of the week, anyone having that slump?
I heard that it's called what is it called hump day?
Hump day.
Okay, I always thought hump day meant something totally different. But then I was told that it means slump day.
Yeah, it literally means.
Yeah.
Yeah. Okay, so guys, we're gonna cover OCD and OCPD. We had that left from the last lecture, and after that, we're gonna start with introduction to therapy. I think we can start now. I think more or less everyone's here. And if people keep joining, then I guess they'll miss out on the first few minutes of the lecture. They'll just have to catch up with the recordings. So my first question is how many, not postgrads, how many of y'all are familiar with OCD? Okay, can you tell me the difference between an obsession and a compulsion? Postgrads, you can contribute now.
I actually wanted Advika raised her hand to explain us about OCD.
Okay, Advika, go for it.
No, um, I don't know the difference between like obsession and a compulsion, but I know what OCD is, and that's what I raised my hand for.
Okay.
What is it?
Obsessive compulsive disorder. It's where there's like a need, like you find the need to do something these many times, or like your room has to be like pitch dark before you can fall asleep, or you have to flick a switch like 3 times or 4 times, or you have like these beliefs that something bad would happen.
So you are familiar with the concept. That's very good, Advika. So I'm just going to break it down. The easiest way to understand OCD is to differentiate an obsession and a compulsion. So an obsession is an intrusive thought, an unwanted thought. It could be thoughts, images, something that causes you a lot of anxiety, a lot of distress. And a compulsion is a repetitive behavior. So a lot of the time, these repetitive behaviors are used to calm that anxiety caused by the thought. So, say an example of a case would be I remember coming across this one individual who was obsessed with the thought of his thought was if I don't flip the switch of this room 17 times, something bad will happen around the world or around me. So his obsession was something bad will happen. And the compulsion was to constantly flip the switch back and forth 17 times to ease that anxiety of something bad happening. Right. So, does anyone have any questions about the difference between an obsession and compulsion? Obsession is the thought, compulsion is the behavior, the repetitive behavior to ease the anxiety that stems from the obsession. And OCD, obsessive compulsive disorder, it's characterized by intrusive thoughts and repetitive behaviors which bring down the anxiety or distress caused by those thoughts. um it's always recurrent. It's not just a one time thing. It tends to become a habit. So again, like Advika said, the washing of hands, someone may be obsessed with, the idea of germs sort of causing some kind of illness or something. The compulsion there will be to constantly wash your hands, right? So this is probably the most famous example, right? Constantly washing hands. But OCD can take on many forms. It doesn't have to be related to just germs or related to just thoughts of death. It can just be a thought that constantly bothers you again and again, which is why you engage in that repetitive action. Okay, and Sindhu's going to cover OCPD. We decided we're going to explain these two hand in hand because they do have some similar features. So over to you, Sindhu.
Okay, who in this group knows Monica from Friends? And how many times have you seen on social media, Monica says, I'm a little bit OCD, or people refer to her as the famous OCD character? And let me tell you, that's far from truth. Nisha, you're nodding. Tell me, why is it far from truth?
So, ma'am, we had this discussion during our PT, and our teacher said the same thing, that she had OCPD and not OCD, because she was more obsessed with orderliness, neatness, cleanliness. There was no intrusive thought, firstly. And secondly, so these characteristics about her personality, orderliness, neatness, rigidity. So that is why she falls more into the category of OCPD rather than OCD.
Okay, what now have you seen characters in different movies? All of you, this question is for all of you, where someone's very, very restless when they're not productive, or very rigid about how they arrange things, what kind of light should stream in their room, and how they want their surroundings to be. It's like their life is organized around control. And OCPD is a way the personality is organized. It's not a disorder. I've always said that all of these PDs are the ways personality or enduring patterns are organized. It's got little to do with an illness, but OCD is an illness, and it has two very distinct features: obsessions and compulsions. And the cycle of compulsion following the obsession keeps OCD alive. There is a significant distress. It can be cured. It can be managed. It can be treated. OCPD is a personality trait, so it doesn't need to be treated. Oftentimes, it will just create a bad environment. People will get pissed off with you because you're so inflexible. You're so particular about things. It's driven by perfectionism. So OCD is an illness, not OCPD. Let's talk a little more about OCPD, the personality disorder. Any postgrad who would like to contribute at this point? Anything that you can contribute as a difference between obsessive compulsive disorder and OCPD? Have you seen cases of OCD?
I have a friend who has OCD and OCPD, so I don't really know the difference, but she has both, and
Less likely.
yeah, but I have seen some stuff with her that is.
So I think it is possible, Shreya, that the diagnosis is not clear. OCD and OCPD do not occur together, but OCPD has a lot of overlapping features with ASD, autism spectrum. So you could have autism spectrum disorder and OCD. You could have OCD and anxiety and depression, but it's difficult for us, at least clinically. It's not something that we've seen for somebody to have, say, a very distressing OCD and then also a very comforting OCPD. Because OCPD does not even dent you, right? It does not create anything. You're just going on your life and you're organizing things. A lot of times I've noticed that, there are some people who would like their knives to be a certain way. Like my mom is obsessed about how things are arranged in her house. Like you can't move things, right? But if that doesn't happen, it doesn't cause her illness. It just leads to a bad argument.
For my friend, I think her most difficult issue, according to her, is the intrusive thoughts.
Yeah.
For her, that is the toughest part of it, because it just makes her hate herself for even having those thoughts when she really can't control them. And so those intrusive thoughts, and she is a bit inflexible in certain things, where if you do certain things, she'll just not even talk to you about it. She will just distance you completely. So you don't even know what happened. She'll just do it. And then she's like, I'm sorry, no, this is my boundary, and this is what you cannot cross. And Yeah, so she is a bit like that about that. Like she's a bit particular about her room,
Yeah.
but like certain things, like you said, they have to be kept in order. Like her
Mm,
books are all alphabetical.
mm,
And she does have a thing where she keeps organizing her makeup again and again
mm.
in like this square pattern almost. And yeah, just stuff like that
I,
that
I
she
think
has.
it's
But the most difficult of it all is the intrusive thoughts for her.
and I want to reinforce and reiterate on that because this is for everybody. Intrusive thoughts or obsessions followed by compulsions, that's the hallmark of an illness. Yes, Zaiba, you've raised your hand. Go ahead.
I just had a question. Can like losing control over thoughts be a major symptom for OCD?
Sorry, say
Uh,
again.
am I audible now?
Yeah, yeah.
Can losing control over your thoughts be a major symptom for OCD? Just like that thing.
What do you mean losing control over your thoughts?
Like you can't stop your thoughts. The thoughts are constantly recurring and they are like random thoughts. Sometimes you're worried about your death. Sometimes you're worried about what you're going to do in life. Sometimes it's this. And it's like on an extreme level. Your functionality, your life has become completely dysfunctional. So can that one thing be
I,
a major symptom?
I would first recognize GAD, general anxiety disorder,
Hmm.
in that particular person because what you're describing sounds more, uh, pertinent to an anxiety disorder than an OCD. OCD is going to appear so distinctly to you. So I'll tell you, a 17-year-old girl from school, she's functional, normal anxiety about academics and friendships. But there are times when she's standing in the morning and they come from a traditional family. When in the morning she's praying, she imagines the gods naked. It's a
Hmm.
thought, the thought just pops in her head that
Hmm.
bad things are happening, or
Yeah.
she's tempted to do bad things with the god figures. And she knows how wrong the thought is. She knows and she hates herself for it. And she immediately has to, change whatever she's wearing to something else, wash her face certain number of times in order to purify herself. So do you see the differences in the symptomology? So a lot of these
One
things,
one example that I had gotten from my friend when I asked her to like, a bit explain it to me what it's like for her. So she explained it with the example of supposing she's painting her nails, okay? She has to do a certain number of coats and she feels, okay, I did 6 coats, but that's like a demon number. So now I need to do 7. But that's not even. Like that's not even. So I need to do 8. But
yeah,
8 is basically 10. So I need to do 10 on all of them. And like that, it's just like it's constantly like if I don't do this, I'm going to die. If I don't
yeah,
do
yeah,
this, like you know how when we were kids, like we used to there's certain squares like checkered floors, and you used to
yeah,
think like this one is lava, I need to step on that one. It's
huh,
that, but on a regular
yes,
basis with anxiety, like
correct.
that
And
multiplied.
Zeba, when you get a client like that, the exploration should be focused on the nature of anxiety and the thoughts, images that come up for her. So, what are the images or thoughts that come up for her? And does she follow it up with distress, or does she let herself be distressed in it? Or does she come up with a compulsive behavior to soothe herself? How repetitive is the pattern? Are there specific ways in which the OC follow, like O follows the C follows the O? So it would require a little bit of exploration, but Zaiba, generally overthinking, excessive worry, I would attribute more to an anxiety disorder. Okay. Because for OCD, we do a very clear test called Y-box, right, sir?
Mm-hmm.
Y-box test?
Yeah.
Okay. Anybody's interested in getting a Y-box analysis done? So no features, anybody doesn't have any features, right? That's great. So I was talking about this kid in school, and so she would change her clothes, and then she'd have to keep repeating. Then say something other than if her parents would step out every evening, she would feel they'd meet with an accident, and in order to prevent that accident, she had to watch or sing a particular song till the time they would get back. The only time she had missed doing it, her mum came a little late and she was very worried that her mom had met with an accident. Now, in order to remove that distress from her life, she has to do these compulsive behaviors. All that's fine. OCD can be treated. That's the great positive thing. How do we treat it? Anybody? What do you think happens? Shreya, you raised your hand? Yeah.
From what I know for her, like from my friend, because I'm speaking completely from her experiences, she's on medication for it. Um, and she does take therapy, but she doesn't do therapy as much. For her, it's more medication based.
So, surprising truth, OCD does not get much help from medication. It can reduce your, your overthinking, but OCD's gold standard for treatment is what? Who wants to say? Come
Where
on.
does it stem from?
What's
ERP,
that, Sir? ERP. Who said ERP?
Mehak.
Yes, Mehak, yes. It's exposure and response prevention. I want you guys to remember it. OCD, gold standard treatment is ERP, exposure and response prevention. In a very simple manner, can Mehak, you explain what ERP is?
So usually in ERP, what we do is that we expose the client to their OCs, basically so whatever they are fearing the most, we try
Hmm.
to expose them to that and then try to make them understand and see that whatever that they were really thinking would happen does not really happen. So it sort of makes them rationally also see and understand that maybe these compulsions and thought formed an association, but in reality it really won't happen or won't matter if we stop doing certain things. So it goes step by step. It's a stepped therapy, so you don't have to like expose them to the most biggest or the drastic aspect of it. We start like, so let's say that um if somebody has this compulsion of going and checking the door lock again and again and again and thinking that if they don't check the door or locks the door in a certain amount of time, something would happen. And they have this compulsion of checking with others, that or asking, let's say asking the mother that have I locked the door, have I locked the door, can you go check the door. So what we'll ask them to do is stop asking the mother to constantly check the door, like let the door
Yeah.
open. Yeah,
So
so that's
correct.
the
What you're saying is we gradiently expose the patient to controlled exposures and we prevent the response. That's why it's called ERP. We are preventing the response from expressing. So the moment we break the cycle between the O and the C, we would have got through. Right? So anybody, Sarah, you see a lot of OC clients, right? You and I see a lot of OC clients.
There was actually this one 12-year-old girl I'd worked with back in college also, and her main concern was, enclosed spaces, crowded spaces. So, as a part of her exposure therapy, we decided to take her on the local train, the subway. And so it started with, first we got her out of the car and had her just stand in front of the station, just looking at all the people, all the hustle bustle. Of course, that caused a lot of distress. We backed off after that. Then the next time we went there, we made her buy the ticket. Then, whatever, even if that caused enough discomfort, we drew the line at that. The time after that, it was getting through the ticket counter with her ticket. And then slowly, eventually, there was a day when she actually had to ride the rail alone with someone. And the next step was to ride it alone. So she went from literally the first stop to the second stop. But that alone made her realize that she could survive it, right? So she gained a little more confidence in the fact that if she doesn't avoid it, something bad won't happen. Like it just sort of is, it's a way of giving them proof, that, if you don't give in to this obsession, then you'll survive. That's
Yeah.
primarily how we went about it.
Yeah. Absolutely. And I often tell OC clients that, look, this is the biggest scam or a conspiracy your brain is planning against you. And you are not going to buy into all conspiracy theories you see on YouTube. Why are you believing in what your brain tells you? So to beat that conspiracy theory, you need to gather evidence, right? And you want to gather evidence in a slow and a sure manner, one ladder at a time. So there are a lot of exercises in cognitive behavioral therapy, which involves gradient exposure. And what Seher shared is a great example because in every exposure, ERP, we do the same thing. At every stage, we have safety cues, mechanisms to make them feel comfortable. So they believe that they are not in disproportionate distress. And then we call debriefing. So debriefing is important too, where we help them understand what happened. So this is all a part of therapy. But OCD versus OCPD, does anybody have any questions about that?
There's actually one more really interesting case I want to share after Zaiba.
Okay, Zaiba, go.
I had a question like, is it possible to develop a personality disorder while you're recovering from OCD?
You can't develop a personality disorder. Chances are you may have already exhibited patterns of those thoughts, beliefs, and the therapist has just uncovered it. So it is possible that, you know, somebody with OCD also has, say, avoidant or anxious personality or, you know, avoidant personality disorder typically occurs a lot with severe OCD.
Yeah.
So in cases of severe OCD, we see that you remember we had done cluster C last time and we had talked about anxious, you know, anxious disorder. What is called APD, right? Anxious personality disorder.
Avoidant.
Avoidant, okay. Yes, avoidant personality disorder. That's most likely to be a co-occurring morbidity.
Yeah.
So personality disorders, nobody goes around analyzing. So it's just when the therapist finds that it's very important for us to now put in cluster just to help the patient understand or help come up with certain things. PDs are not illnesses. They are ways of life, ways we organize things. Okay.
Thank you.
Guys, I
Yes.
just want to share this one example with you because I mean, it's very important to know that OCD won't always present itself as OCD. You know, a lot of times people think it's easy to notice the compulsion and the obsession and sort of figure out. But this one time of a while ago when I was working at the psychiatric facility, this guy from, I think, Uzbekistan had traveled all the way down because they couldn't seem to figure out why he hated men, being around men so much. You know, he had to keep at least like a good 10-foot distance from all of them. There was like a lot of hostility there. And he went to multiple doctors, multiple therapists, couldn't figure out what's up. We ruled everything out. We only figured out in therapy that the guy had OCD and his obsession was every time he was around a guy, he pictured them naked. Right now, when Sindhu gave her example, that's when I just remembered this. You know, he was constantly imagining them naked, be it his brothers, be it his fathers. And of course, it was very disturbing to him. So for him, his compulsion was to physically stay away from them as much as he could, and that led to hostility. But the obsession in that case was picturing every guy naked, and that sort of caused him to stay away from them. Otherwise, you know, that it was a whole thought process to get into. But I'm just saying it doesn't always manifest in the form of.
You're right. In fact, the compulsions can be so well hidden. There are clinical cases of pure O's and pure compulsions where the compulsion is not an outwardly visible behavior, but it could be you thinking a certain thing a certain way that becomes a compulsive process. Very close to what Sarah is describing. I've seen 3 cases where absolutely healthy working individuals have an intrusive obsessive pattern that if they see a child's picture, they will have pedophilic beliefs. They have no tendencies or indications that they like children in a sexual manner. They have never sexualized them. But their fear is that what if my brain suddenly pops up this intrusive thought of pedophilia or I'll end up harming children. In order to prevent that, they would behave differently. So in all of these 3 cases, been different compulsions, but it is the strangest thing. Like the moment you start seeing patients, you realize the human mind takes you on the craziest adventures. And all of these obsessions have a root in some sort of early formation of beliefs, early trauma, or it could be relationship, it could be interpretation of life that wasn't going okay. It could be a depressive episode that was not diagnosed. It could be anything. But the O, when it comes, it never comes as a clear negative thinking. It can come and pop up in the most bizarre ways. And the compulsions are also bizarre. So, this guy would never step out. The guy who thought if he looked at children, people, FBI, he was in the US, so he would think that FBI is going to catch him and they're going to put him behind bars. So he had to, he could never go out. He chose to work remotely. And even when he would work remotely, every 45 minutes, he had to keep resetting the alarms for his house because it turned into paranoia. Severe OCDs are very, very difficult. And imagine when they come to you, you are only seeing a compulsive feature. Or you may not see it at all. You may see just something disruptive. People won't come to you and say that, this is the thought I had in my head. Your job would be to explore that. So it's an interesting work for even the psychologists involved. But one good thing is OCD definitely has a very treatable plan of action. Medication as well as psychotherapy, though medication only reduces the overthinking bit and the distress tolerance. Okay. On to the next thing, Seher. What do you want to talk about?
Okay, so today we're going to be discussing different case studies. That's the topic for today, right? So, and it's also introduction to therapy. So we're gonna, sort of introduce you all to the world of therapy, how it works, the process of therapy per se, where there's going to be case studies. There's a couple of videos also that we want to show you on how different modalities of treatment. Do you guys remember the modalities of treatment that we'd covered in the first lecture? Behaviorism, psychodynamic therapy, all that. So we're going to talk about how we can actually apply that into real world situations. Yes, Mokshika.
I actually had a question regarding something that I studied in class and connected with what I've learned over here. We're currently doing self and personality, and in self and personality, we were doing ego defense mechanisms. And usme there was a sentence where they specified that an unhealthy defense mechanism can lead to a truly warped version of reality and erratic behavior kind of stuff. So I was wondering if that can be connected with the cluster A personality disorders.
So with personality disorders, yes, of course, management, that's the goal of therapy, right? To manage the maladaptive behaviors that we've sort of adopted over the years. So that of course takes work. But that being said, tendencies may not go away. There will be a tendency always. It's just about therapeutically how you manage it, how you work on it with your therapist. It will require a lot of work. And there will still be tendencies because that's the personality type, right? Sindhu, do you have anything to add on to this?
So defense mechanisms are unconscious mechanisms. So most likely the person who's adopted the defense mechanism wouldn't be quite aware of it. It is the therapist who would uncover that for them. And if the defense mechanism turns out to be maladaptive and is causing disruption and dysfunctionality, it can be addressed in therapy. It's a different school of thought. Defense mechanism typically is not in, say, CBT, REBT, in other versions or in the other modalities. If we are talking about psychodynamic theories, then we are talking about defense mechanism. Was that the question? I only caught the last bit.
The question was in ego defense mechanisms, there was a sentence which said that wrong defense mechanisms that are unhealthy might lead to a warped version of reality and maladaptive. Yeah.
For sure. Yes. Yes.
Can that be connected to cluster A personality disorders?
No. No. So it won't be connected to any typical cluster. It can be any of the personality organizations. And your defense mechanisms organize your personality. So it could be A, B, C. So, for example, somebody who's overly rationalizing, overly compensating could fall in cluster C as dependent, right? If they are overly compensating. If they are somebody who like to manipulate or projectively split, projective splitting, they could have borderline and they could fall in cluster B. So it can be not just A, it could be A, B, C. So it's essentially what you're doing is pulling a theory from one place and saying, can it be applied to even understanding personality? For sure, yes. Okay.
Okay. So we're going to start by watching a video. The first one, it's about how we therapeutically would deal with social anxiety. This is a phenomenon a lot of us are familiar with. So we're just going to watch a quick video on how social anxiety would be managed in a therapeutic setting. After that, which we'll open it to a discussion. Wait, I'm sharing my screen. I haven't done this in like 2 days now. Hold on. Okay, there it is. Can you all see my screen?
Hi, Hannah. Nice to meet you.
Hi.
So I understand that you were referred to me by your GP because you've been experiencing some anxiety difficulties.
Yeah. Yeah, I guess it kind of started like 5-6 years ago.
Okay.
It kind of escalated a bit. I've just recently moved out from living with my parents, so it's made it a bit worse, I think.
Okay. Is this the first time that you've left home?
Yeah, yeah, it's the first time actually, yeah. I was going to a few years ago. I just thought it would be easier to stay home. So
Okay, so it's been quite a big step and a big change, and it sounds like that was what led you to go to your GP.
Yeah.
So how has that changed things for you?
It's kind of, I haven't really told anyone, so I mean, it's made it like better in the sense that I feel hopefully this is it. Like it'll help, but I don't know. I don't like thinking that I've like had to do this. I never thought I'd like be the kind of person who'd have to actually go and like get help. If that makes sense.
Okay, so how do you feel about being here today?
I'm a bit like scared. I don't know. Hopefully, it will help.
Okay, so you've been feeling a little bit anxious about today.
Yeah.
Okay, so I guess just going back to why you went to the GP and how you've ended up kind of coming here today. So it sounds like you've been experiencing anxiety for quite a few years, but just recently you moved out of home for the first time, and that was what kind of led you to go to the GP. So how did that change things? How were things after you moved out?
I thought that they'd be better, but because I thought I'd have to kind of be independent, but it's actually a lot worse. I'm just kind of staying in the house a lot. I don't really have any friends or anything. I mean, my family come and visit a bit, but it's not, I don't know, it's kind of scary because I've just been kind of literally just in the flat by myself, which I always thought I'd like, but I don't actually like it.
So what are the kind of difficulties that you have been experiencing?
I mean, I'm a photographer, so I kind of it's been stopping me a bit, my anxiety from being able to get work, and because every time there's an opportunity that is kind of involving me having to interact with people, I just tend to just turn it down. So it's kind of making things hard in that respect, and just kind of friends wise and everything. I just feel like I'm just kind of increasingly more alone. So it's kind of stopping me from making friends and like relationships and stuff.
Okay, so you said that your difficulties are getting in the way of you doing certain things, so they're stopping you from taking up kind of certain types of work. And as a freelance photographer, I guess that can be kind of a problem. And they're also stopping you, or you feel like it's stunting you socially. You're not kind of able to make new friends and get to meet new people.
Yeah. It was kind of easier when I was at home because I was obviously, I mean, my parents, that's fine, but you know, I'd go to places with them, or I'd kind of have people there, but more and more I'm just finding myself just staying in a lot. I mean, I went like 2 weeks ago for coffee with my friends, and the whole time I was just kind of wanting to go home again. So I just don't want to, I don't want that to happen. I don't want to lose everyone. So
So you're kind of worried about where this is going to lead to.
yeah, yeah.
So you said that you first noticed the anxiety kicking in when about 5 or 6 years ago.
Yeah.
So you would have been about 19.
Yeah.
What was happening around that time?
I guess I'd finished school about a year before that. And I mean, I've always been a bit shy at school, but it was never ever like it didn't really affect things as much as, not at all as much as it has been doing the last few years. I guess it just started when like my friends went to university, and I don't know, I felt like I was expected to kind of move out or just do something, and then it just kind of escalated from there. I'd just stop going to parties, or I'd just say no to invitations, or I don't know, I thought my job would help, because I mean, I love it. I really like doing photography, but I'm just kind of getting less and less work as it goes on. So, which is my fault. I keep saying no, but
What kind of work is the most difficult for you in your job?
I guess when I have to kind of be working with other people, I don't like that. It's like when I'm trying to kind of would do an event or something where there's a lot of people there, not just photographers, but actual, you know, if I'm like taking photos of people, that I don't know, I just kind of find myself saying no. I mean, I want to do them, but just it's scary, so I just don't do it.
So I guess tell me a bit more about what happens then. So let's focus on maybe an invitation to do a job with, you know, it's going to involve photography with a group of people, and you're going to have social interaction. What kind of thoughts go through your head?
Just, I mean, I get really hot and sweaty, and I feel like everyone's kind of looking at me and thinking that I'm just like really stupid, and I feel like they're all going to be staring and thinking I just can't do my job and I'm just an idiot. And I mean, they'll think that I just look like a weirdo, and I just try and, I mean, I just kind of just try and get out of the situation or just focus on something else. So that's why I like doing shots where it's just me and the camera, because then I can just put all my attention on that instead of having to, you know, be with other people.
Okay, so it sounds like you have quite a lot of thoughts rushing through your head then at the point where you get that invitation. You think, people will look, people will stare, people will think I'm a weirdo. So there's quite a lot about what you think other people will think.
Yeah.
And how does that make you?
Sindhu, were you saying something? Wait. Your
Yeah. The reason I wanted you to stop is because I wanted to get deeper into therapeutic process as we go further for these kids, because they're not going to be taking, most of the youngsters won't be, other than the postgrads. I wanted them to understand from us, Seher, the idea of therapy and what is the world of therapy. So I love the video. You and I have, seen this, and you know, I want quick observations from it so all of us can have a conversation about it. Is that okay?
Yeah.
Yeah. So I wanted to understand, Shivani, what were your first thoughts when you looked at, let's talk about popular myths about shrinks and therapists.
Sorry, can you repeat?
What are the popular myths, or what are the popular notions people have about what therapists are like?
They just listen to you, and I mean, I think, as far as I think, when my friend was, I mean, my friend does not go to therapy, but she thinks she needs therapy. So, and she's like scared of like whether like maybe they just imagine the person being very formal and not like just asking about their thoughts and invading their personal space. Will they be able to like speak it out? Because they have so much expectations, like if it's like parents itself. If they're sending their child to therapy, they want the child to be okay. And that thought is in their head. And they're just gonna pretend in therapy that, oh, like whatever they're saying, it's helping me, but it's not really helping me, because but then but then I have to like tell my parents that I'm fine, but I'm not really fine. Something like
Ah,
so I
so
think
that's a very genuine barrier where the child feels or the person feels that I need to show up a certain way, or I have to like have an outcome to therapy in order to be a good client.
yeah, and
Like,
also some of I also think that people who like people they visualize therapists as someone who just needs to get procedures done so that they're gonna be okay. You need like a process that has to be done so that they can be okay. They don't cannot go their own way. They have to go in this certain steps itself, and they cannot go in their own pace.
okay, so
I think that
that's myth number one that Seher is gonna break for you. Seher, is that true for us?
Could you repeat that again, Shivani? Sorry, I lost you in the
No,
middle.
so Seher, my question is, do you think we follow our pace or do we follow our client's pace?
The client space.
100% Shivani, all the time. Every therapist will do that. The first thing we need to do is after we become a clinician, we throw all our books away.
Yeah, that's true.
I always tell people, throw your books away. People before processes. Manuals are important to have to give you a structure in your head. But remember, there is a human being sitting in front of you. So if you think you're going to click on the button or show up in a room and say, I'm going to do 5 exercises of cognitive behavioral therapy today, and the person should be better, not going to happen. Because you may just enter the chat or enter the room for therapy, and the person may just be a ball of mess because something happened that morning with them. So in that particular case, you need to be there, right? So people before processes is one line that I need all of you to remember. Okay, and it almost concerns me that your friend has so much of hesitation because it feels like the friend really genuinely needs help because they want to go for therapy.
no, the
And
thing is, I think she went to a therapist because her parents recently got divorced, and and also she's diagnosed with something which cannot be treated. I think it's a health condition or something. Like it's like when she walks, her feet feels like they're not there. It just I don't know. It's called fibro something. Um, I have also been searching around, like, okay, I'm just like there for her and stuff like that. Like recently, her mom put her in therapy in like the online something, and it didn't really work for her. And she told her parents, like she told her mom because she's living with her mom. She told her mom that this is not working for me, and I don't want to do this, and then she just stopped. So now she's just
okay,
like that.
so we need to address myth number two that the moment you meet your first therapist, you'll find the perfect fit. What is the reality there?
Not at all. I'm still trying to find the right one for me. And it's been a while. So, and there's nothing wrong with accepting that fine, this one may not fit you. That's perfectly fine. I mean, if a therapist takes that personally, then that's sort of not a good sign on the therapist's part because
Correct.
everyone has, a different set of skills. Everyone has a different technique, but so you may be a good fit for someone for A, but maybe not for B. It really depends on what the client needs at that point, right? That's our prime focus, to like help the client and give them what they need in that moment, right? So, hi Radhika, welcome.
Hi, Radhika.
Hello, hello,
Okay.
ma'am.
Radhika is also a part of our team along with Nisha, Mehek, Zeba, and welcome to the team, Radhika. My name is Sindhu, and that's Seher.
Hello. I
And the
wasn't
bunch,
sure when the meeting started. I'm sorry I'm late.
okay, and the other bunch of bright kids are the future. And I'm very, very proud of this future. I'm very excited also for them. So, okay, back to myths. Shivani, I love the points you brought up. Anybody else? Tell me some popular myths you've heard about therapists and therapy.
What's the one image that comes to your head when you picture a therapy session? It's the most famous one. Couch.
Yeah, correct. Absolutely. Why the couch? Why is that image? So
I don't know.
embedded.
It's been shown a lot in media. It's like one person lying on a couch and the other person is sitting across, and it's this really serious person with a notepad, and you're
With
just
their legs
writing stuff
crossed.
down. Yeah, with
Their
it's
necks
like
crossed, the notepad in their hands, chashma like this.
yeah,
and
yeah,
okay, yes, this is
exactly.
what's happening to you.
Yeah,
And what is
yeah.
the most annoying line that therapists apparently use? We don't use them, but media says that we use them.
Huh?
What is the
I have
typical
no
line
idea.
that, how do you feel about
How
that?
does that
How
make
does that make you feel?
How does that
Yeah.
make you feel?
I was
But that lady
How does
in
that
that
make you
video was using
feel?
that line every 2 seconds. How does that make you feel?
That's something we should talk about, the idea of Western therapy.
One thing
and
that
ours.
one thing that I've experienced or even heard from people that have done therapy is when somebody passes you a tissue box while you're crying, that can sometimes come off really like, like, okay, stop now, like clean up, that sort of feeling.
Good
When
point.
you pass a tissue box, even though like the therapist might just mean like, you can take your time,
No, let it
start
out.
again, yeah, let it out sort of thing. But to that
Like, you
person,
want me to
okay,
stop?
okay, just wipe your tears, let's start, like that's what it comes off as. That's one thing that I've heard.
Yeah,
With
that's
Mm.
I want to add one thing. I don't know if
Mm.
you guys have watched Love You Zindagi in that Alia Bhatt,
Yeah.
and in that, like Shah Rukh Khan is like, he's like, oh, if you want to cry, you can cry. If you don't want to cry, it's okay, don't cry.
Yeah.
Close the tissue box. It's-
Yeah.
There's
I
like
haven't seen it. A lot of people have been recommending it. I should see it.
no,
I saw it
It's a
thoda
good
sa, but
movie.
it's a good movie. I saw it
It's
thoda
a
sa.
good movie.
Yeah,
It's I've watched that movie
I
multiple
remember
times. It's a
watching
really
that
good
movie in like when I was in 7th grade.
Did you
I
like it,
remember
Maitreyi?
I remember
Yeah.
watching it at that age as well. I did not understand head or tail of it, and Dad and I left the
Yeah.
house.
I
It's
think
one
now
of my
I'm able
comfort
to like
movies.
connect with it more than at that time.
It's one of my comfort movies. I do watch it sometimes. Like I think I haven't watched it this year, even once, but I end up watching it at least once every year, is
It's
what I
that
will
good.
say.
I
I
should watch
really
it
like
then.
it. I think it's a good
Okay.
movie. The one scene, so Alia Bhatt, like right at the beginning, she has a meltdown in front of her family, and that scene is so powerful
Oh, I
because
love
it's like where she goes, "एक और bomb है मेरे पास, I'm taking therapy. Yes, मैं दिमाग के डॉक्टर के पास जा रही हूँ. So अगर आप लोग मेरे पीठ पीछे, yeah. Coco's gone
That's
mad.
another myth that bothers me personally. That's another myth that bothers me personally. We saw it in
Yeah.
that suicidality video as well.
Okay.
You go to a therapist, you're crazy.
I think the worst one is when parents think that it means a failure on their part.
And they
So-
also think that if a child will go to therapy, they're going to therapy only to bitch about the parents. It's not about.
That's true.
Might be, but that's honestly on the parents. It's not on
Yeah.
the kid. Like, I'm sorry, it's on you,
Okay,
like,
what's
if
a
the kid is
typical
bitching about
line?
you,
What's a typical line attributed to all psychodynamic therapists, like traditional therapists? Does anybody know the famous line?
I probably know it, but I won't know unless you say it.
Okay, Mehak, do you know? You nodded. Do you know?
I will just take a guess. Maybe it's the childhood trauma. It's coming
Yeah, so
from
it would be, yeah, you're right. So the question would be, tell me about your mom.
Everything.
Tell me
Every
about
single
your childhood.
Tell me
No,
about
not
your
even the childhood. It would be about, tell me about your mother. So, psychodynamics, fixation, and their focus on that. But look, all of these schools of therapy, they have their own myths and truths, just like shrinks are seen to be a certain way. Listen, I went for an interview to a psychiatric hospital for head of therapy some time back, and the interview went great. And they looked at me and said, you don't look like a psychologist. I said, what does that even mean? And the person said, you look like a soccer mom.
You are a soccer mom.
Thanks,
By
Mopika.
definition, you are. By
Yeah.
definition, you are.
No,
But
that was one thing that my tutor said to me too. I remember I was on call with you, and I think I was having a breakdown, something of that sort. And she said, "That was your therapist?" And I was like, "Yeah." And then she goes, She just seemed like she didn't seem like a therapist. She just seemed like someone who knows a lot, but is a friend. Like that
That's
was
really
what
sad.
she said.
I need to work on this look of
No, that's a
psychologist.
good thing. That's
I
a
know, I'm
good
kidding.
thing.
I'm
It's a
kidding. I'm
compliment.
Because
just
then it won't put off any clients,
Yes,
because you have this
absolutely.
preconceived image of what a therapist will look like, what a
and
shit.
that's what I want all of us to break. I want all of us not to fantasize about wearing cardigans and ugly shoes and carrying coffee mugs everywhere. We can be who we are as clinicians as long as we are.
Why is dark academia being absolutely slaughtered over here? It's a good aesthetic, man. It's not that bad.
The
I'm
number of
going
cardigans that get sold.
and I'm going to walk. No, but I'm going to walk in with the most neon, bright colored cardigan I can find, with the highest 80s style ponytail I can make. See,
You
this is your therapist.
So there are certain schools of
I would
therapy
cry.
that have typical looks also. Like if you looked up on Instagram, you'll have eclectic, psychedelic, and humanistic therapists. All of them have a different look. I mean, it's a popular meme.
I have a feeling that psychedelic therapists are gonna look like hippies. I think that's what it's gonna be like. Evil eyes
Okay.
all over and crystals
Okay, so
around. All of
wait,
that.
wait. So tell me this. So you know that there are so many myths and so many stereotypes around therapy, therapists. What did you notice in the session that you watched? What is something that annoys
She's
you or would
not engaging with the emotions, and what I can see is that the girl is trying so hard to make it lighter. She's constantly smiling, like very awkwardly. It's almost like she's trying to use humor to lighten the mood.
okay?
And she because she kept smiling and being like, like this happens, ha ha ha, like that sort of like constant thing. And the therapist, she wasn't really engaging with the emotions. It was sort of like, yeah, that's normal. Like she was very much just taking it as, okay, it's this. Like it's just symptoms. It's not feelings that the other person's actually dealing with.
How
Like that
important is
empathy
it?
part seemed missing.
How important is it for the therapist to feel the emotions the patient is going through? Do you think it's important for them to feel it, or do you think they should just hold it, hold the
I
space?
think I think it's important for the emotions to be acknowledged. That is
Ah,
just acknowledge them at least, because acknowledgement means, okay, what you're feeling is present and it's valid. I acknowledge that you're feeling that, right? She is just brushing past it and she's like, okay, you're feeling that. How does that make you feel? Okay, so that means she's
I had a
very
therapist like that.
mechanical.
I had a therapist like that, and the first and the only therapist I've ever had, because I haven't gone back to therapy after that. She would we would sit and she would just let me talk, and she would not help me connect anything to anything. And it's just, okay, this has happened. Okay, cool. How you feel? How do you feel? They're not connecting what happened in one session to the other session. It's like having a very, very boring catch up with your grandmother.
Okay.
Oh,
Okay.
wow.
That's
Okay.
harsh. So future clinicians, please listen up. We can't be the boring
Okay.
grandmother. Okay. What is counseling? How is it different from therapy, psycho? So tell me the difference between a counselor, a psychologist, and a psychotherapist. No, no. Anyone else? Advika, Mihir, Maitrey, can you just give me an idea about what does a counselor do? Mihir has to go, I think, in 4 minutes. Mihir, open your mouth, speak something before you leave the call.
Yeah. I'll think. What did you ask again?
Wow, you've been paying attention, my boy.
No. Sorry.
Okay, so what do you make of a counselor's job? What does a counselor do? What does a psychotherapist do? Are they different? Are they the same thing?
They're different, obviously.
How?
I mean, both the cases, they don't recommend medicines, right? They just have
Okay.
therapies and sessions through which they solve problems through
Okay.
talking, and
Okay.
you have
So,
different procedures.
so talking is common, yes. What else?
What else is common?
No, what is different?
That I'm not sure of.
Okay, anybody else? Advika, do you want to take a shot at it?
I have a guess.
I don't know.
Hmm?
I actually don't know.
Okay, Shreya, take a shot.
I have a guess. Okay.
Okay.
Counseling, to me, it seems like it might be more of a corrective behavior thing in a less serious setting. So it's like the lighter problem where it's like, supposing in school you have counselors, right? So it's like in school you have a certain problem, which is supposing like I wouldn't want to say surface level, but surface level problem, and you go to them for that corrective thing. You correct that behavior or fix that situation, more like a temporary fix to a temporary problem. While psychologist or like that feels more official, it feels more formal, it feels like, okay, this is like a problem that is actually there, and it might not feel as temporary, and you go to them for like understanding it better on a deeper surface level.
Okay, that's very good. Anybody else
Yeah,
wants
that's how
to
I
add?
perceive it.
Radhika, would you like to correct the ideas? Would you like to add to what they're saying?
The basic idea is that a counselor guides a person more or less, and a psychologist or psychotherapist, they actually try that the client has insight themselves. They try to solve their own problems rather than guiding them through it.
Right.
So, and
Correct.
as Shreya said, surface level and more deeper level of
Correct.
issues.
Absolutely right. Now, also important to remember that not all psychologists are psychotherapists, but all psychotherapists ought to be psychologists. Right? So you can, finish your master's and, higher studies, and then choose to use therapeutic interventions in therapy settings, and therefore you will be called a psychotherapist. But if you were also a psychologist who went to research, you'll be a psychologist who's a researcher. If you were a psychologist that went to a social work setup, you'd be a social reform worker. So psychotherapy is a specialized field where therapeutic interventions and insights and deeper understanding is shared within the setting. And like everybody said very correctly, counselors guide. They do more short-term corrective planning. Is that correct, Seher? Correct. So we are good. Now,
could you say that psychologist is like an umbrella term almost?
Yes, 100% sure. It is an umbrella term.
So the way I'm seeing it in like a mental map in my head, it's psychiatrist, psychologist. Psychiatrist is someone that prescribes medication. Psychologist, okay.
No. So
then what is that exactly?
So psychiatrists are physicians, are people who have done MBBS. They've gone to medical schools. So they are physicians who then specialized in treating the brain using medication. They're psychiatrists. Okay. They are also mental health workers, right? They're also mental health providers, but they're not psychologists. So they use strictly the psychopharmacological method to get you better. They could have a style of treating like Dr. Satain has, which is like therapeutic, as in he may have a conversation, he may build a rapport with you, something that typically doctors don't do or psychiatrists don't do, right? So he has what we call a psychologist perspective or a therapeutic approach to psychopharmacology.
Okay.
And that, frankly, is the golden combination. It's the perfect combination. A psychiatrist who knows about therapy or understands psychology, or a psychologist who understands molecules. This is where you want to be to become very scientific and evidence-based. Okay.
Understood. Okay.
Okay. Another thing is that, yes, Mihir, you can leave. Okay. Good luck for your orientation.
Yeah. Bye.
Okay, so for everybody else, we are going to, Seher, I was talking to you about assessments, right? So what I'd like Nisha, Mehak, Radhika, and Zaiba to do is pick one kid, Advika, Mokshika, Maitre, Shreya, Shivani, and Mihir. I think there are more, right? I'd like the four of you to run an assessment for each of these kids. So you get one or two. I said you'll have to work it out
Yeah.
on how, how many people need to work with. Sorry, how many kids each can take.
I'll figure that out with them after class. I'll send an update on the group.
And I'd like these seniors to approach it like they would approach a therapy session. So there has to be an individual connection. I'd like you to sit down. Say, for example, Mehak, you want to do an assessment for Advika, her personality testing, or her anxiety meter, or her mood inventory, whichever you pick up, a test you pick up. I'd like you to talk with Advika, run the assessment. I'd like you to write down a report. I'd like you to explain to her what a report means. And the entire thing has to be done in I want each of these kids to get a feel of what therapy can be. Okay? That's what I'd like to do. And I would honestly, this is my idea, I would like one of you guys to do it for us, the entire class next time. So whoever wants to go, we would pick up, one team, and I want the entire assessment and evaluation, sorry, the explanation to happen in front of the class, where you are explaining the outcomes of the report. Is that okay? That can only be if your client is okay. So
to simplify it, I'm going to be shadowing these calls as well.
correct.
The first brief call. So we'll fix up timings with your respective clients. And I mean, I won't be there. My video is going to be off. My mic's going to be off. I'm just going to be there. So no performance pressure. Just putting that out there. But I will be monitoring these. So I'm going to personally send out the links, to figure all that out. But I just wanted to put that out there that I will be monitoring these as well.
And I would like to obviously understand from the rest of the kids, how do they feel where in a therapeutic setup, when they're being assessed, when they're being explained something. So I'd like to hear from all of you who are being assessed, that if you felt comfortable, because let's use very real case studies and simulations to understand how therapy needs to work. Okay? All right. I want to sign off early today. Is that okay? You sure? Okay, awesome. Thank you. It's always a pleasure to chat with all of you. Please take care, and I'll see you all on Friday. No,
And I'll be in touch with you all on
I'll be Friday. Oh, you can do that, Shreya. Wow, that happens? No.
I do this multiple times. When I remember I was on call with my friend and she said something that was like really embarrassing for her, and I just went,
But it's not
heart you."
working.
And it was really funny.
Doesn't
but she
work
was
for
even
me
more
either,
embarrassed.
boy. It doesn't work for me either.
Okay, Mokshika, you can't call me Bua.
Sorry, nikal gaya.
Okay, bye.
Feels odd to call you Sindhu.
Mokshika is my niece. Everybody. All right.
She told me that the first time when we had an interaction, she was like, so basically, I'm her niece. So I
It feels odd to call you Sindhu, man. It feels odd to call anyone over the age of 25 by their first name.
Brilliant.
Okay.
Indians.
All right.
You should come to our school. Our school, we literally call our teachers by their names.
Teachers
Yeah.
We have nicknames for all. We have nicknames for all the teachers.
We have nicknames for our
Yeah.
teachers.
Correct.
Nicknames
They call
everyone
their
has.
principal by the first name.
Yeah.
This is Ryan's school, Mokshika. So yeah.
Yeah. Oh, God.
See, we call, we have a bio teacher.
Okay, bye. Bye, guys. I'm off.
Okay,
You guys
I'm gonna
catch
keep
up.
you guys in the loop on the
Bye.
group. Yeah.
Bye.
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 Okay, so it's the total end of the session. Okay, cool.
Yeah, I'm guessing. Okay. Bye.
Bye.